Hi, morning everyone. Like I say, my name is James Warrington. I'm a consultant anaesthetist at York Hospital. Most of my time I spend working with our pre-assessment service, our CPET service, and also major general and major vascular. What I'm going to spend just over the next 15 minutes or so talking about is a service that we've developed in York over the last 2 or 3 years. There's about 10 consultant anaesthetists and some nurse specialists that we work with. So why was it all important? I mean, firstly, we've already touched on it. The patients that we're dealing with, they're becoming more complicated. The procedures we're dealing with certainly becoming longer, certainly in our institution. But we're also dealing with significantly more complex patients. They've got increasingly complex comorbidities that we need to deal with. We had huge problems 3 years ago actually getting throughput of patients. The patients that were having to go to HDU post-op, we were having to cancel on the day of surgery because we didn't have capacity. And it was really something that we needed to look at and to address to try and reduce the number of cancellations on the day of surgery. There was also massive variation in post-op practice. We had consultant surgeons and consultant anaesthetists looking after patients during the operations. They would then go for one-to-one nursing care with PACU. They would then be decanted out to the wards, and then they were basically being looked after by some of our junior medical and surgical colleagues. And again, we wanted to address some of that. And kind of like alongside that, we were also having problems with failing to rescue a lot of these patients. If there was deterioration in patients, a lot of this was being, it wasn't being noticed until the patients had deteriorated to such a degree that it was much harder to actually intervene at that stage. And finally, we also really wanted to look at some of our complications rates and really look at our prolonged hospital length of stay and try and reduce some of the variation in our patient stay. So I've already touched on critical care capacity. This is us right at the right-hand side at York Hospital. This basically shows, in terms of the number of acute beds a hospital has, how many critical care beds we had. So we had very few in terms of capacity to actually get our patients into. And this was a fundamental reason of trying to address some of our cancellation rates. So what were our aims? Our fundamental aims was, firstly, hopefully to try and reduce some of our complication rates. We definitely wanted to improve our resource utilization, so we wanted to the idea was to take patients out of high dependency and treat them on the normal ward. But on the background of that, they were going to need support from anesthetics, specialist nurses, and also the surgical care team as well. And we wanted to improve this coordination of care between the surgeons and the anaesthetists so that no longer the patients it was as soon as they left the theatre complex or they were out of HDU, they were no longer the anesthetics. We weren't involved anymore. We wanted to get involved in the post-op care to try and improve some of the comorbidity and to reduce some of this huge variation in practice that we were seeing. We also wanted to look at fluid management with a lot of these patients. Now, this is the River Ouse. It floods once or twice a year. You can see the King's Arms here. It's an interesting pub. Beer is dreadful, but it's still relatively cheap, certainly compared to you guys down here. But it does make it interesting as you're drinking there and the floodwaters are starting to lap in at the door. But why is this up there? The reason this is up there is because we're still giving our patients far too much fluid. Even though we've had a huge drive on fluid management in the wards, the default position, if a patient's blood pressure drops or urine output drops, is to give them a fluid bolus, give them a half a litre, give them a litre, see what happens. When nothing changes, what do? We give them more fluid. And before you know it, you've got a patient who's 4, 5, 6, 7 litres positive. And this chap, a couple of years ago now, but this was from the journal in Australia, he actually went home 10 kilos heavier by the end after his 8-day hospital stay. Ridiculous. Patients do not need all this fluid. We're still flooding our patients with fluid. So we wanted to address some of these ideas. So we applied for a grant from the Health Foundation, which enabled us to what we sold it was we were going to improve our pre-assessment, standardize our intraoperative care, and I'm not going to, because of time constraints, I'm not going to go really into any of that today. But what we specifically wanted to do was to improve our post-operative care. So actually get anesthetics and intensivists actually involved in looking after these patients post-operatively. We specifically wanted to protocolize blood pressure and fluid management so that it was actually delivered by nurses rather than the doctors. And we developed various nurse-led and nurse-delivered algorithms. So rather than, if the blood pressure dropped, rather than the nurse having to go and speak specifically to the surgical team to get fluids prescribed, there was already something in place for them to kind of improve the blood pressure or include urine output. Along with this, we also funded a perioperative nurse specialist, and Andy Scott, who's with us today, he's over there, he'll be quite happy to answer questions later on for you. But this is the fundamental kind of like key working between the anaesthetic department, the surgical team, and also the nursing teams on the ward. And to be honest, without the support from the perioperative nurse specialists, this project wouldn't really have worked. Finally, we also wanted to back this whole project up with anaesthetic-led ward rounds on our existing surgical unit. So the idea was that we were going to remove patients from our high dependency, put them onto the normal ward, and actually support the nurses, the surgeons, with critical care style ward rounds. So all our patients were assigned a various pathway. They went on to one of two protocols. One, the vast majority of our patients, 70%, they were treated on a standard pathway, which was essentially just good quality nursing and surgical care. The other patients, the kind of our highest risk individuals, so these were all assessed at CPET, so all these patients would have had a CPET test, and based on various parameters on that CPET, we would determine whether they were low, intermediate or high risk. Our highest risk patients, we felt it was probably a step too far to remove them from high dependency, but I'll come back to those in a little bit. It was the patients somewhere in the middle, those patients that would normally go to high dependency, but probably could go to the ward. And these were the patients that we were specifically looking at. And this was 20% of our cohort of patients, and we quote them in mortality, in hospital mortality of around about 3%. So it was those intermediate patients that we were specifically wanting to look at. So when I talk about protocolized care, what do I actually mean? All the patients in that intermediate risk group would go to our surgical ward. They would have an arterial line, they would have flow monitoring, and then based on various parameters, whether it's blood pressure, urine output, lactates, we would then make a decision, or the nurses would make a decision on what to do with a drop in blood pressure. They would either give them a fluid bolus, which was already prescribed, or alternatively, if it wasn't a blood pressure problem, we would start vasopressors. And so this was the first time that we were actually introducing arterial lines and vasopressors to essentially a non-critical care environment. This is an example of one of our protocols. There was all sorts of safety features built into it. So if lactates were going up, if patients had had several fluid boluses and weren't actually responding, then there was immediate referral to either high dependency or to outreach, depending on where they're fitting it. So we've been doing this for 3 years now. We find it something that works for us. The last time we had a significant amount of data was from a trial that York was involved in, which was a crystalloid versus colloid trial back in about 2014-15. And so we used that data as our kind of like control group. We then introduced our service. We started bringing patients out of high dependency. The actual groups are relatively well matched. Our laparoscopic rates, as most other places, have increased over the last kind of like 4 or 5 years, but otherwise the groups are relatively well matched. And what have we found? We found that our mean and median length of stay have both decreased, but it was specifically, it was the variation in the difference between the length of stay. That's what we were looking at, and the variation between some of our long stayers significantly reduced. What about complications? Again, complications, both major complications, so grade 3 or above, or minor complications, both of those also dropped over the 3 years compared to our control group that we were working with. When you look at some of our fluids related complications, our ileuses, that kind of thing, again, we had significantly less problems with ileuses and fluid management issues. And when you actually look at how much fluids were being given, intraoperatively, we were essentially given the same. Nothing had really changed. It was the post-op period, and that was where we were trying to stop this routine program of just putting up an 8-hourly bag of saline or Hartmann's. And our post-op fluids significantly reduced, and importantly, the fluid balance at 24 hours and into the post-op stay also reduced during that period. So in summary, what were some of our lessons from this over the last couple of years? We feel that high-risk patients can be safely removed from critical care and be nursed in the ward environment. You've all seen, you go and see your patients in high dependency the following morning. The patients are still in bed. They've still got all the lines and catheters in. They're not eating, they're not drinking. You go and see them on a specific colorectal ward or a surgical ward. Before you even got there, the nurses have got the patients out of bed, catheters out, drips are out, and actually the patients are up and about and moving. Things are actually making some progress. And that's what we noticed. And although we've concentrated on some of our intermediate patients, what we've also started doing is to bring some of our higher risk patients now out of high dependency and to treat them on the colorectal ward. Because in terms of a recovery for the patients, as long as there is something in place to pick up any deterioration in the patients, that's where we're wanting to go. We know that ward care is not always of an optimal standard. And to be honest, a lot of the peri-op stuff that we do and the ward rounds that we deliver on the nurse-led surgical unit, most of it is just a simple attention to detail. It's making sure the patients have got the beta blockers prescribed. It's making sure that the diabetic meds are sorted out. Surgeons are fantastic at dealing with the surgical complications related to surgery, but what they're not trained to deal with is all the other comorbidities associated with surgery. And some form of cardiorespiratory ward round given by intensivists and anaesthetics, I think is probably beneficial to these patients. And finally, like I've already mentioned, Andy and some of our other nurse specialists, they were the fundamental key to this project. They delivered all the training to the nurses to be able to deliver and have arterial lines safely on the ward. They're the key link between us and the nurses, the surgeons as well. And so without those or some form of nursing support, it would be very difficult to run. This is our website. There's lots of information on there. All our protocols and all the pathways and on what we do are all on there, which you're obviously more than welcome to have a look at. And thank you very much.